Hello, welcome back. This is Professor Young for part two of two, looking at tissues and how tissues behave and perform. This WIMBA session should be considerably shorter. We got a couple little things that we need, little loose that we need to tie up that I didn't want to try to force into the last session. Just because I think it would have made it too long, and so we're gonna spend some time tying up some loose ends. One of those loose ends that I know we need to look at is intercellular communication, and what I mean by that is how exactly do epithelial cells, or simple scratch that, how exactly do squamous cells communicate with squamous cells? How exactly do cuboidal cells communicate with cuboidal cells? How do cardiac cells communicate with cardiac cells? There is a mechanism in place that allows for very consistent communication between the tissues. And in short, what we are really referring to is this term known as intercellular junctions. An intercellular junction is really a gap that forms between cell membranes that allows for communicative signals to be passed from one cell to the next. There are two types that we have. One that prohibits communication, and one that encourages intercellular communication. And so you will see here, tight junctions is going to be the type of connection that is going to restrict or prohibit intercellular communication, while leaky junctions are definitely going to encourage communication. So why don't we go ahead and start with tight junctions and spend a few minutes looking at this and really looking at how these guys play a role together, and we will kind of go from there with that. So first thing, tight junctions, as their name applies, is going to seal up those spaces where cells communicate with one another. And so it prevents materials from moving from one cell to the next. If we go back to the structure of a cell membrane, remember that we characterize cell membranes as being selectively permeable. And that selective permeability, this here is not a no. That there is indeed an I. This concept of selective permeability lends itself to this concept of tight junctions and leaky junctions, right? Because what a tight junction does is it increases the selectiveness and it decreases the ability for a membrane to be permeable. As an example, we want tight junctions in place in the kidney, in the bladder. You don't want that material that is being stored to leak out. You don't want that information or that product to diffuse through osmosis, move across the cell membrane. And so what ends up happening is you can see it right here, right along here. What ends up happening is where those gaps would normally be, it seals up. It almost forms like a quilt or a piece of like Charmin bath tissue, if you would. All right. Now, the actual gap itself, or the actual junction itself, is located right there, and right there. All right, now what would happen is wherever you see one of these little circles at, that would represent another junction, another gap junction. And again, in the case of tight junctions, these junctions are sealed off to prevent or reduce intercellular communication or intercellular interactions. All right, now, the opposite of that would be leaky junctions. And these would really be channels that are able to be open to allow for effective and consistent communication and transfer of material from one cell to another. And so what ends up happening here is the junction, again, is right there and right there. And you can see they're all along here. And when these guys open up, information very effectively flows across into other cells. And when they're closed, they can restrict that. And so leaky junctions have that ability to regulate the flow, whereas tight junctions do not have that ability to really regulate the flow in between the cells. And so that's really what I wanted to touch on there with that. Now, as we go forward, a couple things that I need you to think of here. And this also lends itself to tight junctions and leaky junctions. And it gets to the heart of what I've been trying to explain in lab with the concept of, organs are made up of multiple tissue types. And these tissue types need to be able to work together to do the function of the organ. And that's all stuff that we've learned and we've talked about. And this is just going to bring it home for you guys, hopefully a little bit more clear. All right. So each organ is designed and set up to do a specific task. All right. At any point in time for that given organ, a certain tissue type is in charge. So in other words, in the stomach, your smooth muscle is in charge. All right. Smooth muscle is in charge. In the lining of your intestines, pseudostratified ciliated columnar cells are in charge, or simple columnar cells are in charge. In skin, stratified squamous is in charge, or your squamous epithelial tissue is in charge. All the other tissues that are associated with those organs are there to assist the tissue type that is in charge of carrying out the function. And so the tissue that is carrying out the function, the tissue that is doing the work of the cell, is what we refer to as the parenchyma. And so the parenchyma of an organ is the tissue that is doing the function of the organ, whereas stroma is that other tissue that is surrounding it. It becomes the tissue that is there playing a supportive role in the process. So parenchyma is doing the work. So in the stomach, the parenchyma is the smooth muscle. All other tissue is the stroma. In the intestines, the columnar cells are the parenchyma. Everything else is stroma. In the skin, the epithelial is the parenchyma. Everything else is the stroma. In the nervous system, the neurons are the parenchyma. Everything else is the stroma. And so that's how this kind of plays back and forth and works off of one another. The cuboidal cells that are found within the kidney are the parenchyma. Everything else is the stroma. So, each of the tissue types have a means of being front and center, so to speak. And as well, each tissue type has that ability to be that supportive role as well. Within the heart, cardiac muscle is the parenchyma, everything else is stroma. And I can keep going on and give you examples of that. I think you've got that, and you understand that. Okay. I think you have a good grasp on what's going on there. Now, again, this WIMBA session here is just kind of about tying up loose ends that we have for this look at tissues. Right? And so one of the other things that we need to look at here is tissue repair, changes that can happen in tissue, and ultimately tissue death. We talked about the fact that all of our tissues really arise from one of those three embryonic germ layers, either the endoderm, the ectoderm, or the mesoderm. And I've thrown around from time to time this term, differentiation. And I don't know if I've ever really clearly defined cellular differentiation or not. But what happens is cells are able to change form. All right, and so when and that ability to change form is what we refer to as cellular differentiation. Cellular differentiation. When we get into the skeletal system, we're going to notice that within the skeletal system, cells can go from being an osteoprogenitor cell to an osteoblast to an osteocyte, and then eventually into an osteoclast, which is kind of a different animal there. But the lineage, the family tree of being able to change from an osteoprogenitor cell to an osteoblast to an osteocyte is an example of cellular differentiation. Each of those cell types that I just mentioned have a specific form and a specific function. And so really when we're talking about cellular differentiation, we're talking about the change in form and function of a cell type. When we talk about differentiation, we're talking about the change in the form and the function of a specific cell type. Osteoprogenitor cells are stem cells. Osteoblasts are producing bone. Osteocytes are maintaining bone. And so as those three cells change into one another, the form and the function of that cell type also changes. The act of changing from one cell type to another, the act of changing from one cell type to another is what we refer to as metaplasia. The act of changing from one cell type to another. All right, and this is something that we actually see happen quite a bit, especially in epithelial cells. Metaplasia is one of those terms. And by the way, plasia here means to change, and meta here is form. And so this is literally a form change that takes place, and we very often see this term metaplasia kicked around very often in cancer patients, because what ends up happening is the cells change cell types very often, and they change not only the type but the form and the function as well. And so the metaplasia is kind of that act of undergoing change, whereas differentiation targets specifically the form and the function. And so differentiation falls under this category of metaplasia. And I'll give you an example. We know within the nasal cavity that we have lining that root pseudostratified ciliated epithelial columnar cells. Well, if you're ever bored at some point in time and you've got a couple of days available and free and you're not doing anything, if we were to go ahead and take a sample of that tissue on day one and put it underneath of a microscope, we would clearly see pseudostratified ciliated columnar epithelial cells. Now, from that point, if we were to go ahead and let's say put cotton or tissue up the nose of one nostril, all right, and let it sit for about 3 or 4 days and come back into a sample of the nostril that was clogged, into a sample of the nostril that was open, what we would see is the nostril that was open would still contain pseudostratified ciliated columnar epithelial. But the nostril that was clogged, due to a lack of use, the pseudostratified ciliated epithelial columnar cells actually begin to change. They undergo metaplasia. And they go from being pseudostratified ciliated epithelial columnar cells to being stratified squamous. They lose their functionality completely. It falls under that old adage, use it or lose it. And the body does that quite often. And there's a lot of other examples of that as well that I'm not going to go into. But know that that does definitely exist. All right. Let's talk a little bit about how tissue repairs itself. All right. Some tissue is more readily apt, if you would, to repair. Other tissues are not as readily adept to repairing itself. We know that neural tissue within the central nervous system does not easily repair itself. In fact, once you have damage to those cells and then once you have cell death occur, at least within the central nervous system, we have not had very good luck of having cellular regeneration or tissue regeneration. Now, in the peripheral nervous system, such as neurons or neural tissue outside of the brain and the spinal cord, we do have some ability to repair. But not all tissues repair themselves equally. Not all tissue types repair themselves as frequently. The liver does not repair itself all too easily, although it can, and it actually can regenerate itself. And so if you lose 25-30% of your liver, you can actually regrow parts of the liver. And so that is something that's a little bit different. Now, when we talk about regeneration, what we're really dealing with here is the replacement of dead and damaged cells. And sometimes it does that, and there's no lasting effects, and there's nothing that you can really see as a result of that. But sometimes we get something that is referred to as a scar or scar tissue. And what we are really saying here is with a scar or scar tissue, the clinical term for that is fibrosis. And that's a term that, when people say, oh, I suffer from fibrosis, what it is a collection of scar tissue. The chiropractor guy that I go to once a month or so is actually now doing tissue manipulations under general anesthesia, where they go in and especially people that are suffering from back pain that have fibrosis. In other words, they've had some kind of spinal injury, maybe they've had back surgery before, and they've lost mobility within the back because of a buildup of scar tissue. What he's starting to go through and do is under anesthesia, going in, making tiny incisions, and going in and basically breaking up that scar tissue and removing that scar tissue. And what they're finding is when they go in and they remove those fibroids, that mobility begins to increase, pain begins to decrease, and people in general are feeling a whole heck of a lot better. And so, and again, what they're looking for is a collection of fibroids or fibrosis, this buildup of scar tissue that really becomes desensitized. You don't have any nerve endings into that area, And so you lose functionability when you develop scar tissue. You lose that ability for that tissue to function at a normal rate or function normally in general. Now, here we've got a person here. She was making dinner. She cut her finger. You can see that this here is probably on the fingertips or something like that. It's thick skin. We know that because of how thick the epithelial, the stratified epithelial layer is there. And what ends up happening here is blood, if the cut's deep enough, enters down into the dermal layer, as you're seeing happening right down here. And that blood, the vessel is nicked, and blood is going to flow up through that cut, and it's going to reach the air. Now, once it's reached that air, it is bringing not only with it red blood cells, but remember fibrinogen. Fibrinogen is going to go ahead and begin to reconstitute itself as fibrin. But even before any of that happens, a specific type of white blood cell known as mast cells are brought into the area. So the first thing that's happening in this area is mast cells are brought in. Okay, now mast cells, again, are a type of white blood cell. And what these mast cells do is they trigger a release. It triggers a release of two things. It triggers a release of one, histamines, and two, heparin. The first thing that's done. All right, now, both of these guys, both histamines and heparin, are considered to be blood thinners. And so the histamines actually dilates the blood vessel. The heparin thins the blood coming up through those blood vessels. And that may sound counterintuitive. If you just cut yourself, all right, blood is supposed to remain inside. All right, so why, if you just cut yourself, is the histamines going to cause vasodilation and dilate the blood vessels, bringing more blood, and the heparin is going to thin the blood, which means it's going to flow even more. Well, think about what that does. What that allows two things to happen. The blood flow that is now coming out is going to immediately begin to disinfect the area. It's going to try to remove any kind of foreign debris that was brought into that cut, because now you've got flow moving out of the body, so it's going to wash it out. That's the first thing it does. Second thing it does is it really brings in a rush of red blood cells, white blood cells, and also brings in a lot more fibrinogen that's going to reconstitute itself as fibrin and begin to form the scab. Right? That's the first thing that really needs to go on here, is that fibrinogen needs to begin to form the fibrin that's going to form those safety nets to catch red blood cells and to plug up the cut. And so we've immediately tried to remove any debris by forcing blood up and out. We've caused vasodilation. We've brought more blood into the area. We've thinned it out. And so that way it's going to hopefully wash out any kind of foreign particulate. Next thing we knew is, now that we've got that fibrinogen that's hitting the air, it's going to form the fibrin, which is going to cap the cut. It's going to form a blood clot. Right? And that's exactly what we want. Now, what that does is we've immediately disinfected the area, quote unquote. We've tried to remove any pathogens. That blood clot is going to prevent any new pathogens from getting in. And that's key. Right? And immediately we have a response from the immune system. that happens here in step 2. You can see here there's this term, and it's a little fuzzy, but I think you can make it out. All right, right there. Oh, sugar, that wasn't right. Right here. We've got this term macrophages. Macrophages are a specific type of white blood cell lineage, and what they do is they eat away bacteria, they eat away any kind of foreign particulate, any kind of bacteria, any kind of virus, any kind of debris that may be entered in from the cut. And the other thing they're going to do is they're going to eat, they're going to break down, they're going to clean up any dead or dying tissue that's within the area of the cut. And so they immediately, these macrophages immediately begin to go ahead and begin to break down dead, dying, destroyed tissue, as well as other things. So we've got our scab that is formed. We've got blood that is entering up into the area that is helping to form our clot. All right, that blood is also releasing or bringing to the area macrophages to allow for the cleanup of dead tissue or damaged tissue that may have arisen. Right? And we also have a couple other players that are standing by. We've got leukocytes, which are other types of white blood cells that are going to be perusing the area for bacteria. And we also have fibroblasts. Right? We also have fibroblasts. And the fibroblasts are going to be there to begin the healing process. Right? Keep in mind, we've cut down into the dermal layer, and so we're going to need to create some more dense irregular connective tissue in that area. Those fibroblasts are going to be able to start producing the fibers. They're going to start being able to produce that amorphous ground substance that is lacking in that area at that present time. Now, step 3. All right, we've increased blood flow. We've washed away some of the debris. We've caused some blood thinning. We've formed the clot. Now that the clot is formed, some macrophages have been brought in. The macrophages are beginning to break down the dead, the dying, the damaged, the destroyed the cells. We've got leukocytes that are waiting in case any bacteria is going to be present. And we've got fibroblasts that are also on the scene as soon as everything is ready to go to begin to rebuild the scaffolding that's going to raise up and heal up the dermal layer. All right. From there, all right, now that we've got all that kind of good stuff going in, notice, all right, right down here, all right, that blood vessel has repaired itself. All right, that blood vessel has repaired itself, which means we no longer actively have blood flowing up into that scab. And so what ends up happening is macrophages were left in that area. They're still cleaning everything up. Right? They're going in, they're cleaning up all of that debris. But what also interestingly begins to happen is down in the dermal layer, new blood vessels begin to form. So we have new blood vessels that are beginning to form. The fibroblasts are starting to become active, and so they're laying down more amorphous ground substance. And as they lay down more amorphous ground substance, they build up and begin to repair even further that dermal layer. Typically, new collagen begins to form within 3 to 4 days of wound. All right, so that collagen, which the fibroblasts are going to be creating, begins to be laid down within 3 to 4 days of the wound initially happening. Everything is sealed off here. We don't have blood going to the area anymore. We've got dead tissue being digested. We've got the repair of the dermal layer. And so what actually begins to happen is the macrophages that have been brought into the area actually begins to also break down the scab. And so the scab begins to break down by the macrophages. Right? So the scab is now also being broken down as well. And the final stage to healing here is once the repair has been done to the dermal layer, the simple squamous that makes up the basal stratum, or the stratum basal, right, which is right there. Okay, that right there is the stratum basal. Okay, once the dermis has been repaired, then the stratum basal can be repaired, and only until that happens, and what we can look upon as being quote-unquote stage 4, can the stratum basal begin to become active again and form new epithelial cells. And that's exactly what happens. The epithelials begin to undergo mitosis. They begin to divide. And as they begin to divide, they go up into the stratum spinosum, where we know that they begin to enlarge. They lose that ability to become meiotically active. And from the stratum spinosum, they go ahead and they move up into the granulosum and the lucidum, and before you know it, it's back out into the stratum corneum. But all of that is going on underneath of the scab. As the epithelial cells that originated from the stratum basal reach the stratum corneum, which is right there, once those epithelial cells that originated from the stratum basal begins to reach the stratum corneum, what will end up happening is the epithelials of the stratum corneum will push off the scab. Right? So in other words, what's happening is underneath of that scab, you've got new skin. And that new skin just kind of forms, through pressure, pushes up and off the scab. Now, what will also very often happen is in the area of the cut, yes, you formed new tissue, but that tissue may not function normally. That tissue may not function normally. In other words, you've formed kind of a fibroid down underneath, and that's mainly going to happen in the dermal layer, and it may very well impact the epidermis as well. Right? Sometimes it does, sometimes it doesn't. Depends on how severe the wound was. Larger wounds, it will definitely show through. Slight wounds, we've all gotten paper cuts. It doesn't immediately form to develop into scar tissue that you can see on the outside. Has it formed underneath? Sure, it has, but it doesn't always show through. Now, just because you have scar tissue, and just because you have a scar, let's say, on the surface, does not mean that over time that scar will not disappear. It very well can. In fact, it may take up to 2 to 3 years for that scar tissue to dissipate. And so anywhere from 2 weeks on up to 2 to 3 years, that scar tissue can be present. All right. And so it takes time. That scar will eventually usually be replaced with epithelials. Again, it depends on the severity of the injury. Now, last little thing that we need to consider, and that is cell death. Right? There's a couple of different ways in which we can damage the cell to the point where it is not going to repair itself. And once it reaches that level, that is where the cell eventually just dies off when it's beyond repair or regeneration. A cell can undergo atrophy, where it loses mass and very often loses strength and will lose functionality. We see this happening all the time when with muscle atrophy. People who are bedridden very often lose muscle mass, and that's literally what they're doing. The muscle cells die off. People who are bulimic or anorexic very often undergo severe atrophy to the point where they don't have enough muscle mass to actually have the heart beat or the lungs function or anything else. Not a good thing. Necrosis is early cell death caused from an infection or toxins. Very often, spider bites are toxic, or snake bites are toxic. And those toxins will cause liquefaction, or where the tissue just literally liquefies. Typically, it's some kind of nerve agent or something like that within the toxin. And that's necrosis. Infection can set in and literally start to eat away and, again, liquefy to where the skin becomes watery and mushy and soft and just not even really there anymore. That's cell death. Infarction is a specialized type of cell death that is involved with cardiac muscle. And so when you undergo ischemia, which is depriving tissue of blood supply, that tissue will die. And that's exactly what happens during a heart attack. You have coronary arteries that you have two main coronary arteries that feed the entire heart structure. And if they become blocked, you deprive that muscle below the blockage of any kind of blood flow. And when that happens, very often the muscle dies. And so infarction is the death of cardiac muscle, and it's more often what we refer to as being a heart attack or cardiac infarction. Gangrene is an infarction outside of the heart. It's where we deprive tissue, skeletal tissue, as well as other types of tissue, of an adequate blood supply, and literally the tissue dies and rots in place. Stinks to high heaven. Again, it becomes very soft. It liquefies itself. I mean, what you're literally talking about when you have things like necrosis and gangrene that is setting in. And by the way, notice the difference. Right? Necrosis is specifically from some kind of trauma to the body, infection or toxin, whereas gangrene is specifically depriving that tissue of a lack of blood and oxygen. But what happens is those macrophages come in and they just begin to rip apart the tissues. It's dying off and they're breaking it down and they're breaking it down, and you've got bacteria that are setting in, and that bacteria is damaging more tissue. And as you damage more tissue, more macrophages are brought in and more white blood cells are brought in. And white blood cells very often do more harm than good to the surrounding tissue. Plain and simple. You look at neutrophils, which is a specific type of white blood cell. Neutrophils can have the ability to form killing zones around themselves, which is a toxic gas that is partly made up of hydrogen peroxide. And anything that comes in contact with that gas, it kills off. Now, you've got to remember, when you pour hydrogen peroxide onto a wound, you're creating a chemical reaction that's killing off not only bacteria and infection, but it's also damaging the good tissue as well. And that's what happens with gangrene. It happens to such a great degree. Same thing with necrosis. That you no longer have blood supply going in, you no longer have oxygen going in, and you just have a stagnant pool of skin that is just sloughing off. It's turning black. It's getting, it reeks to high heaven, and it just liquefies itself. I mean, just utter grossness is what's happening within that. And then you have the more subdued apoptosis. Apoptosis is normal, programmed, timed cell death. Our cells are not meant to live on forever. And they all have a life expectancy of their own. And so when those cells die off, as they are supposed to, we refer to that as apoptosis. And so we have some different ways in which cells can die off. All cells, neural tissue have a different rate of apoptosis than what cardiac cells do, which have a different rate of apoptosis than what epithelials do, than what connective tissues do, than what bone does, than what cartilage does, than what blood does. They all have their own rate of apoptosis. But it's normal and natural. Right? And so there you have your different ways by which these tissue types that we have talked about can repair themselves, and how they can also not repair themselves and go off to the other end where the tissue dies off. Hopefully I have not grossed you out too much with that description. I have spared you any pictures. I could very easily put some really, really gruesome pictures in here. I'm not going to do that. Maybe I'll show it to you in lecture. But again, if you have any questions, please do not hesitate to shoot me an email. Reach out and ask those questions or even during lecture. And so with that, I'm going to leave you to doing some more studying, and we will have some more WIMBAs up shortly for you.